Good morning, good afternoon, everyone who joined us today. I'm Benedict from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Welcome to this third webinar in a series on transforming care for small and sick newborns. The series organized by the World Health Organization and UNICEF in collaboration with the Network for Improving Quality of Care for MNCH. You are all muted during this call, so that we actually have our presenter being able to present without interruption. But please do join the conversation and do contact the presenter in the chat box, which should be at the bottom right corner of your screen. So while they're presenting, please type your question about the presentation, and in the last 20 minutes of the webinar, we'll be reading out this question and they will answer them. Today, I would like to introduce you to your facilitator, which is Dr. Ornella Vincetto, who is a senior medical officer for newborn health at the World Health Organization in Geneva. She's also worked as a lead editor on the report Survive and Thrive. Ornella, please, over to you. And you need to unmute yourself. Yeah.
Have you done?
Yes, go ahead.
Good afternoon and welcome to all of you to this webinar. Today we are discussing, as mentioned, the chapter 3 on delivering care, the health system components to deliver care to small and sick newborns as they are entitled to it. The report, as you know, has been prepared by with support of a number of organizations, as you can see here, to advance progress on reaching the Sustainable Development Goals 3.2 on neonatal mortality. And I would like to introduce the participants of this, the agenda and the participants of this session. So we have first the presentation of the key findings of the chapter done by myself together with Sarah Moxon, who is a research fellow at the London School of Hygiene and Tropical Medicine. Then we will have a short presentation on improving care practices in the neonatal unit in Ouagadougou, Burkina Faso, as part of the NEST project for Francophone countries by Dr. Paula Ouedraogo, director of Saint Camille Hospital in Ouagadougou. We will have also a presentation defining the characteristics for innovation to support the care of newborns in low resource setting by Becca Kirby, Market Access Director for a Newborn Essential Solution and Technology within the NEST 360 project for Anglophone countries. Then we will have a few slides I will present on the latest guidance of COVID-19 in pregnant women and newborns for what relates to the health systems, and we will conclude with, as usually, with the question and answers. So it is my privilege to take you through the chapter 3 on together with Sarah Moxon and present how care should be delivered to all small and sick newborns in need of it. And the chapter has key main messages. One is that fundamentally we have cost-effective evidence-based solutions to prevent newborn death and disability as well. But we need to make them available and with quality and a high-level coverage. Quality requires integrated, resilient health system, but multidisciplinary teams, and of course innovation to accelerate progress. And then we also need to address inequities in care and reach marginalized populations. So to possibly disability-free survival, solutions must reach all newborns in need of them. And so therefore we need to look both at coverage as well as quality of dignified care. And we need to, in the discussion that we are having regarding the cost-effective impact intervention, we need to ensure that those interventions for the care of small and sick newborn are incorporated in the universal care packages in the countries. At the same time, it's not only looking at coverage that is important, but also looking at the quality. That doesn't make any sense to have increased coverage without quality. And so we need to transform care and ensure that the quality is provided, and particularly family-centered model of care are implemented. In order to do that, WHO has launched together with the UNICEF and partners the Quality, Equity, and Dignity Network in February 2017, with the aim to reduce by 50% the maternal and neonatal mortality and stillbirth within 5 years in the target facilities. And both in general, as well as the quality, equity, dignity, we use the quality of care framework, which set out exactly the values of quality, equity, and dignity. And within the system approach, provides a framework for on how to address the quality of care, particularly looking at both at the provision of care as well as the experience of care as it is experienced by the newborn, by the mother, by the family. And in practice, good quality services are those services that have all these 8 elements in place, that are well organized, evidence-based, accessible, and resourced by with motivated human resources, but also physical resources, and are used, and in this way are also safe and efficient and people-centered, and in this way we'll be able to provide optimal clinical, developmental, and also social outcome for small and sick newborns. And for being able to provide sustainable quality of care, the leaders in health facilities need to cultivate a culture of evidence-based practice among the care providers. And of course, they need the standards and protocols in place. And to help in that respect, the WHO with partners WHO has published the standards of care for maternal neonatal quality of care in facilities, and is in the process of releasing also standards of care specifically for the care of small and sick newborns. And these standards are important because they can be used to develop national guidelines and protocols, as well as to for strengthening the education and the training for programs for healthcare providers. And an example of Mother care is, for example, an evidence-based intervention with demonstrate a high impact in terms of survival, but also in brain development, with the many benefits as not only for the family, for the newborn, but also for the families and for the care providers, in the sense that it demonstrates a reduction in the hospital stay and also a reduction in the cost of care. And but it's not implemented at scale, and we strongly recommend its use among the intervention to accelerate progress in countries. Another special elements that we recommend very much in the chapter is in the context of improving quality of care and transforming the systems is to pay more attention to delivering developmentally supportive care for small and sick newborns, because excessive handling and in general many of the procedures in the neonatal units can disturb the newborn sleep, the growth, and can simply represent a stress that can interfere with optimal brain development. So there are a number of recommendations on how to minimize this disturbance in terms of clustering care, encouraging contact with parents, and pay attention to the environment, the light position of the baby, light, sound, pain, etc. And in particular, we know that many times small and sick newborn are exposed to painful procedures, and these painful procedures may have actually important effect on brain development, and so therefore the one important element is also in the recommendation that we are in the policy and the changes we would like to see in the facilities is also to pay more attention at this at the issue of pain management, and especially having healthcare providers trained in recognizing pain cues in these babies, as well as competent in prevention of pain and management of pain. For small and sick newborns to survive and thrive, the family needed to be able to access services that are appropriate and are properly organized. So in terms of organizing, the simplest way of organization is through the 3 levels, if you like, and where we know that at the primary level, all newborns require basically immediate essential newborn care, but specifically for this chapter, we wanted to focus on the care that needs to be provided at the secondary, tertiary level. We think that the majority, that will be, sorry for the mistake, it should be around 20 million babies every year, could be managed. Could be managed successfully at the secondary level of care with interventions that are low cost in some way. And while only a small proportion, around 8 to 10 million babies, should require the care at the neonatal intensive care, these are the very premature, very small babies, or those who are very sick. And we know that as we improve, expand the services at also the need of additional resources, because tertiary level service compared with secondary level are more complex. In general, to be able to provide quality of care, we need to look at the number of resources, and these are what you can see in the slides are the physical resources that are required. So certain infrastructure, many times neonatal providers are struggling with the availability of space, for example, just space for having the parents there for kangaroo mother care, or infrastructure in terms of water, wash facilities. But we need also technologies, medicine, equipment, diagnostics that are appropriate for the small babies. And we need innovation in terms of, because we know that innovative and cost-effective technologies, innovative and cost-effective technologies, but also innovative approaches have the potential to accelerate progress in terms of quality of care for small and sick newborns. And in fact, in the next presentations, we will see how Burkina Faso, but other examples of how this is, with a systematic approach, we can improve quality of care. I would like to pass now the word to Sarah Moxon, who will continue with the requirements for providing quality of care.
Thank you, Monica. Thank you. So moving on from the what is needed to provide care for small and sick newborns, we need to think about the who provides care, and fundamental to the provision of quality care for small and sick newborns is consideration of those people that provide that care. So small and sick newborns require multidisciplinary teams of competent and motivated health professionals, and the majority of the care will be provided by nurses. We know through studies carried out in neonatal units that the survival of small and sick newborns is very closely linked to the number of nurses working per shift. And this is critical, as we know in many low and middle income countries that nursing numbers and having sufficient numbers of or sufficient health workforce to provide care is a significant gap. But it's not just numbers. For health providers to be able to deliver quality care and people-centered care, we need to think about issues such as attractive recruitment policies. So that's consideration of things like accommodation and housing for staff in more remote areas, recognition of good performance, appropriate sufficient remuneration for skill set, and of course working conditions. Newly deployed nurses may need extra supervision and, sorry, Ornella, do you mind just going back to the slide? Newly deployed nurses need supervision and, of course, opportunities to be mentored. And we may need to think in some countries where there are particular staff shortages about task shifting, which is, of course, a process of delegation whereby more simple tasks may be moved to less specialized health workers to free up more skilled health workers to carry out complex clinical tasks. And this needs to be formalized to prevent any confusion in roles and responsibilities. We need strong pre-service education in neonatal care. And this is not just for nurses, but also for doctors. Expansion of neonatal cadres, if they exist in countries as they are starting to, or where a neonatal cadre for nursing doesn't exist, thinking about a phased introduction. And of course, innovation is needed, linkages between universities and facilities to consider quality improvement programs and education and mentoring. Next slide. So it's not just health professionals that are providing care. We want the families to be ever present, and it's a key aspect of quality care. And this is not just the mothers, but making sure we involve fathers and, where appropriate, extended family in the care of small and sick newborns. And so a health system's values, culture and leadership needs to be supportive of this approach to family-centred care, with accompanying policies and practices and resources aligned accordingly. There are numerous benefits to involving families in the care of small and sick newborns, although very important to note, and increasingly research is showing that this parental involvement should not be seen as a substitute to qualified staff on the shift, but rather a way of enhancing and supporting parents to be involved in the care of their small and sick newborns, which has numerous benefits. It can boost the parent and newborn attachment, ensure higher breastfeeding rates, facilitate earlier discharge from the facilities, and certainly also involving kangaroo mother care, improving long-term neurodevelopment, encouraging interactions between parents and the small sick newborn through developmentally supported care, and of course in the long term improving health-related knowledge and beliefs among parents and communities. Next slide. Sorry, Ornella, next slide. Can we move on to the next slide on yeah, it's okay. Thank you. So this slide shows how nurses can really act as leaders for quality improvement. We know that nurses provide the majority of care to small and sick newborns and are very well positioned to be the primary drivers of change and leaders in quality improvement. And this is really a way of simultaneously empowering the nursing cadre and also institutionalizing quality improvement in our approaches to neonatal care. So we've got a number of examples here of nurses becoming drivers of change and catalysts in quality improvement despite the numerous challenges they are facing in different settings. Next slide. So now we're moving on to the section on transform and really thinking about how we can reduce barriers and discrimination so that we can reach all newborns and families. Next slide. And the Convention of Rights of the Child is a fundamental right for newborns and their families to be able to access the healthcare they need. Currently, we actually have limited data on the overall proportion of small and sick newborns who can access care. And in the longer term, measuring effective coverage will help us to support evidence-based planning to improve access to quality care services. But some particularly important equity issues to consider includes thinking of particularly vulnerable groups, which may be migrants and ethnic minorities, girl newborns who are subject to discrimination in some settings, as well as newborns with congenital abnormalities. And of course, those newborns that do not have families or that may have been abandoned or orphaned. The importance of these considerations is underlined by the fact that neonatal mortality is usually highest for the babies born into the poorest households. Next slide. So this slide shows us the results of a study that was carried out on effective coverage of newborn services in Nairobi City County. This study supplied evidence to policymakers and providers to improve service planning, quality and care delivery. And if we look at the pie chart on the left, we can see that the study found that only 25% of small and sick newborns in Nairobi City Council accessed high quality facility-based care. And looking at the grey area of the pie chart, 44.5% of newborns in need did not access any facility-based care. Whilst a large number of the facilities that were actually studied in Nairobi City County were private facilities, so 29 out of 33 facilities were private sector, the remaining 4 facilities actually accounted for over 70% of all of the neonatal admissions. And this means that these 4 public facilities, within them, specific issues were found with understaffing and overcrowding, which of course accounted to higher mortality in these settings. Next slide. So this slide shows us a bit more about how China has addressed some social and financial barriers using social autopsy. Next slide. A really critical issue for us all to consider is newborn health and humanitarian crises. And of course, this will be exacerbated by the current COVID-19 situation. The table on the right shows us that of 16 countries with the highest neonatal mortality rates, 11 have experienced recent humanitarian crises. So any global response that we are engaging in to improve maternal, newborn and child health must include an explicit focus on humanitarian settings and mobilizing resources to ensure delivery of protective and life-saving resources. There are a number of guidelines that are available on service provision for newborns in humanitarian situations, which are shown along the bottom left here. And this includes the Newborn Health and Humanitarian Settings Field Guide, which was recently compiled by Save the Children, WHO and UNICEF. Of course, there's also the Minimum Initial Service Package for Reproductive Health in Crisis Settings, and the Interagency Field Manual on Reproductive Health in Humanitarian Settings, as well as core operational guidance for infant feeding in emergencies. Next slide. So in conclusion, to end preventable newborn and child deaths, care for small and sick newborns requires high coverage of quality neonatal services. And we need to think about family-centered models of care within those that are organized in a network of facilities that have functional referral systems. We need sufficient numbers of healthcare providers, and this will involve a specific focus on nursing that have skills to care for small and sick newborns that work in partnership with parents and families. And within that, we need to think about reaching marginalized populations. Thank you. So now I'm going to hand over to Dr. Paul, who's going to talk about Burkina Faso.
Paul, you can unmute yourself and start presenting.
Okay.
If you share your screen, please. Yeah.
Yes. Okay. Do you hear me?
Yes, can you make it full screen, please? Yeah, perfect. Thank you.
Okay. I can go ahead.
Yes.
Okay. Hello, everybody. I will present neonatal essential survival technology next program in my country, Burkina Faso. The St. Camillus Hospital in Ouagadougou, who was founded in 1967 by the Order of St. Camillus. Our neonatal unit opened in 1974. The situation in 2014, when we began the program, the next program, was the following one: lack of space and increasing number of admission, limited presence and qualified staff, only nurses and nursing assistants in the neonatal care unit, and lack of adequate technology, high number of outborn babies, and high neonatal mortality. We had about 43% of neonatal mortality rates, and coordinated collaboration with external associations. So we felt that we need more structured approach to improve the care for neonates. We began the program, the next program, in 2014 with our needs, trying to set up the best possible neonatal for our hospital, trying to identify essential drugs and basic equipments for neonatal care in terms of simplicity, adaptability, cost, and maintenance. One of the big jobs we did is the training of our health workers in the neonat department, increasing competencies and local staff through bedside teaching. We also collaboration with Pediatric Society and the Healthcare Ministry and the Institute IFRIS, who is a private institute, to have a master program in neonatology to form our nurses and doctors in the neonatal field. One of the important program was to have empowerment and recognition of parents and families in our strategy, and also working together with the Pediatric Society and the ministry to have shared guidelines and protocols, because before each hospital had its protocols, and we are now working inside of the network of collaboration we are setting to have the same guidelines and protocols in the country. One of the important things of this program is also to give importance to the collecting of data. Data recording and management can help us to understand if we are going on in a good way or if there is something to change. To do the assessment, we use tools from the WHO in 2018, but before we used the tool of our health ministry, looking deep in the buildings and facilities we have, the staff, the quality of the staff, and also the collaboration with mothers and families, the equipment and drugs, networking and collaboration, involvement of higher level institutions within Burkina Faso. So in April 2017, we had the opening of a new unit, and we additional spaces for our babies in a new organization with intensive, semi-intensive, and pre-discharge. We also have a room dedicated to mothers for breastfeeding, and we begin to introduce a new technology like CPAP for pregnancy, machines for jaundice, and other devices like each devices, and also equipment to keep warm babies. We set it also a new organization for the staff with daily meeting, clinical meeting, and also having inside specialists like cardiologists and all radiologists for the monitoring of the babies. We set it also a yearly training program for our department, the support of eternal experts coming from Italy, medical doctors who are collaborating with, and also the pediatricians and gynecologists from Burkina Faso. Most important we felt is the collaboration with pediatricians and also gynecology to take to dialogue and look for the best for the babies. The important thing in this program is also families. We dedicate a room for kangaroo mother care and also a staff for that activities. And also we allowed families and parents to enter and to be close to their babies. For the choice of the technology, we look above all the proved efficacy, the low need of maintenance, the low cost and adaptability to the condition. The use a new technology, we have every time training before, training also trainers to help the new entering healthcare workers. In addition to the success of our model is attention to the financial sustainability, supporting other hospital departments like imagery, putting solar panels, and also having a unit for production of oxygen. Also giving to the nurses, the doctors, increasing their number, and also giving space to the families like partners of the healing program. So this brings us to a collaboration and a network with the other hospitals, with the Burkina Faso Pediatric Society and Gynecologist Society, and with the Health Ministry, the partner with the partnership with international organization and experts with institution. So the next step is to strengthen the data collection system better, so that you can use it to analyze the causes of death of babies, to establish a functional perinatal network in Ouagadougou in collaboration with the other centers, expand the training program at OSCO, and for the perinatal network, reinforce the engagement of the institution with Ministry of Health and SOBIPED, the Pediatrician Society, and at least to promote a formal neonatal nurse qualification with the master, and we hope this year. Thank you very much.
Thank you very much. Now to Becca Kirby. Sorry, I need to mute. I'm now handing over to Becca Kirby, who works with the Newborn Essential Solution and Technologies Consortium, or Next 360. Becca, if you can start your presentation, please.
Thank you. So thank you, Bennett, for passing it off. And thank you, Dr. Paul, for really sharing those experiences in Burkina Faso, where it demonstrated a successful systems-based approach. So in shifting gears, we're going to now focus on the innovations themselves, which are just one of the many tools and components that you really need to get right in order to improve newborn care. So earlier we heard from Dr. Linchado about the different levels of care and the resources required to provide that care in the different health systems. So whether that's the primary or the tertiary level, and how human resources and health technologies vary in those different levels. So for this section, I want to dive a little bit deeper into the actual innovations themselves, which, as I said, go hand in hand with many other components that are needed to deliver quality care. In order to better understand the landscape of innovations, the first thing that our team did was take a look at what technologies already exist out there. So our team spent some time cataloging what technologies are commercially available and in the development pipeline, and that were specifically designed for resource-limited settings, generally at that special newborn care level. And we compiled a landscape aggregating these resources. So in the second edition, which is currently available online at the NEST website, our efforts identified 63 technologies from 29 different organizations. And since innovations continuously evolve, the landscape's updated every 6 months on an ongoing basis, and our next edition is actually planned to launch later this month, featuring 70 technologies. However, we do know that even though technologies currently exist, we're all too familiar with the equipment graveyard, as you can see demonstrated in this picture by these broken and unused oxygen concentrators, which means that something isn't working properly in the system, and we need to carefully examine to what extent those existing technologies are meeting the needs of the setting. And so therefore, in parallel to the landscaping process, we went through a process of defining the needs of users in resource-limited settings to determine what does it truly mean to be effective, affordable, rugged, and easy to use. So this required defining the characteristics and creating target product profiles, or TPPs, to help guide innovations so that we can really define what the characteristics are that are needed to support the care of newborns in hospitals in these resource-limited settings. And we did this in partnership with UNICEF, who I can see some friendly names on the attendee list who are joining us on the line today. So to create the TPPs, we identified 16 different product categories that fall within 6 different pathways of care, ranging from jaundice management, so phototherapy and bilirubinometer, to the biggest pathway, which you see here on the right, respiratory support. A rigorous process was followed to inform the development of these TPPs. So first, a review was conducted to define the product categories and the initial set of TPPs. Those initial TPP drafts were then sent to 180 key stakeholders, which included clinicians in low and middle income countries, product developers, NGOs, procurement officials, just as some examples. And these 180 stakeholders were asked their level of agreement and disagreement with the characteristics that were defined in order to solicit their feedback. And a significant amount of feedback was actually gathered from these surveys. So a consensus meeting was then held where 69 participants gathered in person for a 2.5-day session in South Africa. And the purpose of this meeting was to finalize the characteristics where disagreement existed and to gather everyone together to share their opinions. So I recognize a lot of familiar names in the attendee list who we were fortunate enough to have participate in that TPP consensus meeting with us and share their feedback. And it was a very lively discussion. So over the course of those few days, we captured a lot of great feedback. And after the meeting, we incorporated those feedbacks and changes and refined the TPPs. So while that whole process took over a year long to finalize, we ultimately did create a report summarizing that very dynamic discussion. And we published the newborn target product profiles, which are now available on the UNICEF website. And we again wanted to say a very special thanks to the UNICEF Supplies Division for their close partnership throughout the process. We really couldn't have done it without their collaboration. And again, this was a very vast team effort, and we are incredibly appreciative of everyone who participated throughout the process. So I will now pass it back to Dr. Linchetto to discuss the COVID-19 implications for newborn care.
Thank you. Now I have to put back the presentation. Just a moment. Okay. And now we will spend the last 4 minutes to discuss a bit what are the latest on the COVID, as you know, there's been, we are very worried basically about the indirect effects of COVID-19 on maternal neonatal deaths and stillbirths. And modeling that has been published in the Lancet a couple of weeks ago shows that pregnant women are at high risk of mortality and negative outcomes because of reduced access to to facility births or births with skilled attendants. And this is due to a number of factors, deployment of staff for care of COVID patients, or also reduced care seeking by the women themselves. And the same happens for newborns that are in general less likely to die from COVID-19, but are at increased risk of dying because their needs are not addressed due to a disruption of services. So WHO and the UNICEF have developed a number of operational guidance to facilitate, encourage countries to maintain the continuity of services. So you see the operation guidance on maintaining essential services during an outbreak, which is a bit a generic guidance published initially by WHO, has been followed by a more practical guide on community-based healthcare, including outreach and campaigns in the context of COVID-19 pandemic, and published by partners together with WHO. And then yesterday has been published also the operational guidance called Maintaining Essential Services, Operational Guidance for COVID-19 Context, where we have developed a specific chapter on the life course, and this is what I want to share with you. So fundamentally, the maternal neonatal health services during the COVID-19 must continue, must be protected, and are considered essential services. And to ensuring continuation of services, programs have to look at the capacity both at facility and community level. In terms of the like antenatal care, postnatal care, all the essential elements of routine care must be maintained, but how the care is provided in case of disruption of services or difficulties on providing services as usual. In this case, there must be some adjustment. So in this case, programs need to prioritize high-risk mothers and newborns. They need to incorporate outreach strategies and eventually catch up contacts if some women seems to have missed some services, and also the use of digital platforms for counseling and for screening of danger signs and following up. Some of the families can be done, on distance through these technologies. Now, regarding delivery and immediate postnatal period, all women and newborns should have access to skilled care at all times, and this includes also referral for management of complications. And within that, we need to ensure the birth companion. We need also to encourage skin-to-skin and early initiation breastfeeding, because the advantages of this intervention are much higher. The benefits are much higher than the risk of COVID-19. And then, of course, we need to have all commodities and supplies in stock and available all the time for antenatal care, childbirth, and postpartum care. And finally, there are a few recommendations on the care of small and sick newborns. So the possible adaptation that countries need to consider is, in the context of COVID, is to limit the number of caregivers providing kangaroo mother care support to 1 or 2 persons instead of being open to the entire family. This person needs to be, of course, the mother and eventually 1 or 2. They need to be trained on infection prevention and control, and the use of protective equipment in case the mother is also COVID positive. We need to develop also strategies to enable support to continue kangaroo mother care at home, and because one option is to consider early discharge with follow-up for those preterm and overweight babies who are stable and are still require kangaroo mother care. And the parents before they enter in the intensive care unit or the special care unit, actually as well. They should be screened for COVID-19. There are also detailed guidelines that have been published last week, updated on the clinical management of COVID-19. You can find the management in case of pregnant or lactating women are suspected, have a suspected or confirmed COVID-19. And there is a link. Thank you. I've concluded with this, and I would like to hand over to Bene for the next
the question and answers. Thank you very much, Ornella. Thank you, everybody. I hope the sound is still good. We had quite a few questions coming in as our four presenters today were going through the presentation. The first one was for Ornella from Harish Kumar asking what indicators one need to collect for KMC and what should be the minimal duration of KMC to achieve optimal benefits.
Okay, should I reply immediately? Yeah.
Yes, please. Yeah.
On the optimal duration, this needs to be of KMC. This needs to be tailored to the individual baby. But fundamentally, what we recommend is cells. Actually, they are able to indicate when they are targeted to be in kangaroo mother care. And this usually happens when they are reaching the 40 gestational weeks. That is one. And in terms of duration of discharging from the facility, we have also some recommendation. Usually we recommend discharging from the facility when the babies have at least are growing 3 days and the mother is able to manage, is confident in managing for the baby. Indicators is a big question and it's not easy. There are many challenges in deciding the indicators for kangaroo mother care because depends on the capacity of the facility to collect good data in terms of the numerator as well as the denominator. And there are, but fundamentally, there are some, how do you say, some indicators that are for kangaroo mother care that are under testing at the moment. So the number of babies who are, preterm, but now and are managed in kangaroo mother care immediately or continuously or intermittently. And it's not an easy. I don't have actually a good answer for the indicators. I'm sorry for that.
Thank you, Ornella. We have a question for Sarah on the presentation from Nahia Salim, asking how was the coverage versus access versus those in need analyzed?
So this is with reference to the Kenya study of effective coverage of services in Nairobi City County. And I think that later David Gattara will be presenting in more detail this particular case study. But my understanding, so the question is coverage versus access, I believe. So there is a publication of the participants, so they're actually able to see the ways that each of these things are defined, and I can share this in the I'll share this in the chat box to all the participants so that you can look at the details of that study in more detail. But I also would encourage you to listen into David's presentation later as well.
Okay, and you will send the publication that I can then send as a follow-up to. We will send all the presentations.
I don't want to misrepresent the minutiae of the methods for this, so I'll put that.
It's fine. We have a second session of this webinar at 1 p.m. Central European Summertime, where the Dr. Gattara will present the finding of this study in some details, and we will send the link to the publication to all of you tomorrow with the recording and all the other presentation. Another question for Sarah from Grace Irimu, who said that neonatal deaths in NBUs, most of these deaths are preventable at delivery point, but how do you deal with birth asphyxia? How do we bring the maternal expert on board and let them have interest in the quality outcome of pregnancies?
I think this is a critical question, and certainly when we talk about care of small and sick newborns, we're not trying to suggest that attention to quality of care in the labour and delivery room should not also be paid, but it's about thinking about the care continuum and working closely between nurses and midwives not only having the skills to care for babies that are not breathing at birth, but also for babies that may be born small and sick. Question, but I think that it's important to stress this is a care continuum and that we should be working together. Nurses and midwives should be working together, pediatricians and obstetricians, and that of course we should always be focusing on quality of care around labour and delivery and at the time of birth, but also that there will be a certain portion of babies that will still require care in a neonatal unit. So we're really focusing on that in this presentation.
Mm-hmm. A question for Paul from Tomomi Kitamura, thanking Paul for the experience from Burkina that you have shared. Given the current situation of COVID-19, do you think it's possible to change the training modality from bedside to online training? Paul, you're on mute, so you need to unmute yourself.
Yeah. Okay. Do you hear me?
Yes.
Okay. So I think we can improve. We are trying to improve the organization inside of the neonatal care unit, giving attention to the hygiene devices, and also trying to explain to the mothers and to the families and coming inside of the unit to collaborate. And we have a good collaboration. We put some devices to clean and wash hands, and hydroalcoholic solution for them, for each baby. And also they have to change their clothes and also try to be clean every day, 1 or 2 times in the day. They have to wash themselves. So we have the good collaboration. And also for our team, we have an entrance separated for the healthcare workers. So they have to leave. When they enter, they have to leave the cloth of the city, change themselves, wash, and also we separate the spaces so that they know that passing, going from one place to another, they have to pay attention to each baby and to wear mask. And also in each room, we have 2 or 3 points of washing point, so that this is very important. The washing chain. I think it's important to continue in this way. Trying also, we have also a room for to isolate the suspect cases. In Burkina Faso, we don't have many cases of COVID. for the babies. But we have to pay attention and to try to manage very well for prevention. I think that, yeah.
Thank you, Paul.
Thank you.
There is quite a few more questions for you on the funding, on the training. Sorry. One of the questions is from Priscilla Wabil. Somebody is not muted and have to mute themselves. Thank you. One of question is from Priscilla Wabil on the training, asking how the training for the of the is funded.
This question is for me.
Yes.
Okay. The training program, we discussed it at the beginning of the year with our medical partners, neonatologists, and also the Chiesi Foundation, who is helping us in this program. And also we have consulting from our experts in Burkina Faso. And we train our nursing group with topics about essential cares and also how to manage equipment and also hygiene, prevention, and how to keep warm babies, how to help families, and also to dialogue with them, allowing them to be inside, so we can have a humanized and safety way to take care of the babies. This is a topic very important for us. So not only technical formation, but also the attention for the families, and also to dialogue with the birth room and gynecologists and midwives. And so our nurses, they know that their attention is on the babies, but also on the families, and also they have to have a good collaboration with the birth room. So there, it's okay.
Sorry, you have more questions. We're going to take one more question for you, Paul, and then we have one question for Becca, and we only have 3 minutes left. So the next question, the last question for you is from Samuel Guala. Sorry if I mispronounce this, asking how many facilities NEST is covering and how do you maintain or narrow the no-do gap when health workers are rotating between facilities, or when you are working with health workers who are less experienced in newborn care after the training?
Okay. In this moment, with the help of the Pediatrician Society of Burkina Faso, and also WHO and UNICEF and the Gynecologist Society, we have involved 9 birth centers in this program. And we are sharing. We don't want to work alone, but to try to build something together with the others, sharing guidelines and also sharing protocols. So in this moment, we have 9 big centers inside of our network, neonatology network.
Thank you very much, Paul, for these details. And again, we will share your presentation with everybody who is on the line today. We have a last question for Becca from Rajiv Tandon, asking how the rugged products got WHO PQS and country regulatory approvals.
So from the WHO PQS standpoint, I'll actually defer to Ornella, but from the TPP standpoint, what we did is we defined characteristics for what regulatory bodies needed to approve, and then quality management systems that were required as well, along with various utility requirements, such as what backup battery and voltage are required to help better define what rugged meant, and then also have those regulatory bodies approve.
Thank you. Ornella, you want to answer the first part of the question about WHO PQS? You're on mute. Ornella? Ornella, you're on mute.
Yes, we participated in the discussion with on the development of those TPP, and yeah, and in WHO also we have it's not with our it's not with our department, but we have in Department of Medical Technology all a system to look at the various technologies, equipment, supplies, diagnostic, etc., and for the different population groups. So that is how, and they every year look at the number of those, and to look at the efficacy, safety, the cost, the applicability also in the context of a low resource setting. So there are a number of criteria that are used. And then the technical working groups, once look at all these criteria, they decide if to include which ones can be included in the list of technologies.
Thank you very much, Ornella. We will stop the Q&A now. We have had more questions that I will share with the speakers after this. We cannot. We run out of time now, and I'm handing over to you to close the session.
So, well, first of all, I would like to thank you, all of you, for so much for your participation in this webinar on the care of small and sick newborn and the health system components. We heard that we need to ensure high coverage of evidence interventions. So we need to ensure quality of care, which includes many elements on the provision and on the experience of care, and also motivation, human resources, and sufficient other inputs like technical resources. We also finally we discussed that the importance of addressing inequity to ensure that all marginalized population are reached as well. And this is particularly important in the context of COVID-19 as well, when the gains that we achieved are challenged nowadays because of the pandemic. So more efforts than ever are needed to ensure that all small are receiving the care they need. And I invite you to attend the next webinar, which will be on 17th of June, when we will focus on ensuring the small and sick newborn thrive, and we will discuss what does it mean thriving and what are and how to ensure that the survival would be without disability and with the best chances of development for these babies. Thank you very much.
Thank you very much for your time. Bye-bye.